faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Mission Neve webinar. And the topic is New PPH Guideline, Changing the Way the World Saves Mothers. So it's my privilege to introduce the expert and program director of this webinar, Dr. Sharda Jain ma'am. Ma'am is the director of Life Care IVF Center, fondly known as Teacher of Teachers. I welcome you, ma'am. And it's my honor to introduce the moderator of this webinar, Dr. Archana Verma, ma'am. Ma'am is the Vice President of Foxy in 2021, Founder President of West UP ISOPAP chapter. I welcome you, ma'am, and I hand the session to you.
Thank you so much. So first of all, I want to say my namaskar to our respected teacher, Dr. Shardajan Madam, and today's great speaker, Dr. Ambuja, and today's convener, Dr. Taruchaya. And so all these three are really working hard to make this mission work on every corner of the India, because as we know that mission neve especially was made for this purpose only, for uniformity and a united strategy to combat postpartum hemorrhage, and one of the most preventable yet deadly causes of maternal mortality. Everybody think that they are doing delivery and they have never seen PPH because they have managed the thing so well. But I think this is something we must again rethink and relearn, that PPH can occur in any patient and anywhere in any facility, irrespective of the hemoglobin status or the blood pressure status, or even the singleton pregnancy or primary or multi. So if we know the how to prevent PPH in the first case as a prevention of PPH, and then secondly doing the by on giving timely uterotonics, then timely AMTSL, and then timely early diagnosis and early response, and early and quick and bestest escalation techniques by using PPH bundle. And when we work in this cycle, it really will definitely empower the gynecologist also. So today, before we start the session, I welcome Dr. Tarugupta to say a few words about the Rajasthan chapter of this Rajasthan pupil and Rajasthan, because Rajasthan is doing quite well. And still, I think she should say a few words about that, because she is the main convener of this program. And then we will ask Dr. Ambuja.
Thank you, Archana ma'am, and Sharda ma'am too, for giving me this opportunity. Actually, Rajasthan is starting doing well in last few months or last 1 year, because earlier there was so much of maternal death because of many reasons, and one of the reason is the PPH. But since we have started this mission neve and we have started telling people and teaching people so many well, and they have now learning and putting the protocols in their labor rooms so that they can manage the things so well. So maternal death rate is decreasing. 117 to it has come to 89, thanks to everyone who is helping us for this. And we assure everyone that we will continue to do this, and further escalation of lowering in maternal death, we will start helping other people in this. Thank you, Archana ma'am.
Thank you. Because my concern was whole nation was it was in shock when there was one PPH death in Rajasthan, and then the doctor also did the suicide. So that was not acceptable at any cost, and because we have to empower our gynecologists also and make them confident also, and just let them know that we all are together. Don't worry at all. Like unless and until you communicate, you talk to your friends and teachers, well, then no one can help. So to help our friends on patients both, we have to be connected. So now Dr. Ambuja is a very well decorated person, and she is president, she was president of the Indian Menopause Society from Hyderabad, and she's retired professor and HOD, and she's a very senior professor in Osmania Medical College, Hyderabad, and now she's visiting professor at Savita Medical College, Chennai, and All India Vice President of Family Planning Association of India. My God. Okay. She's a faculty and resource person in National Board of Examination. Madam, आपको
Dr. Archana
नमस्कार
ji,
and like
namaste.
I must say, I must say that peer reviewer of Jogi, the Journal of Ops and Gynae, who can know better than you, madam. Welcome and all. We are all honored to have you. So welcome, madam. Welcome. Now stage
Thank
is all
you.
yours.
Thank you very much, Dr. Archana, for your kind introduction. Are you able to see my slides? Hello?
Not yet.
Not yet.
Hmm.
Okay, just wait. 1 minute, please. Sorry.
Yes, yes, yes.
Share. Share now.
Now, yes, started coming. Now we can see. Yes, yes. Now, only thing is you have to do full screen.
Yeah.
Yes, done.
Good afternoon, everybody. Dr. Chaya, Dr. Archana, Dr. Sharda Jai, and I'm here able to see my teachers, my professors, Dr. Satyavati, Dr. Saras Chandrika. And today we are here like this is because of the teachers. So I'll start with the Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Sri Guruve Namaha. When we were doing duties, Madam Saras Chandrika and Dr. Satyavati, we did duties along with them. And we learned PPH treatment is only because of them, I'll tell you. And as Archana Verma said, I've done so many deliveries, I have not come across PPH. I cannot believe this because anybody who does deliveries, they will come across and you should know how to treat them. And today we are going to discuss about the bleeding after birth, that is PPH. Why to discuss means already Dr. Archana told. PPH is the leading cause of maternal mortality rate. We are hearing about this prevention from the time we joined the medical college. Lot many suggestions time and again are going on with the WHO, but they are not fully implemented. I appreciate Dr. Sharda Jain for taking this message to nook and corner of India. And I can say that Yuddha Pratipadik, like it is aage le ja rahe. Thanks to Dr. Sharda Jain, Taru, Dr. Archana Verma, and making me part of this mission. You know, MMR is it is the index of health in any country. Global MMR is 197, but 92% of the deaths are occurring in the low and middle income groups. And it is in single figures in the high income group. And 80% of these deaths are preventable. According to Press Information Bureau, India's maternal mortality has come down in 6 years from 130 to 88, means that is reduction in 86% of the cases that is present. But still, there is a lot to be done to reduce it to the SDG goals, that is by 70 by 2030. But in some of the country, when states we have achieved, like Kerala, Karnataka, and all, very high rates are there in Assam, UP, and Uttarakhand. Come to the PPH, the incidence is 2 to 4% for vaginal deliveries, and cesarean section is 6%. Rural areas, it is the double number of this thing is. Maternal mortality as a cause of MMR in India is 27%. Now, coming to the new definition, why we are taking this subject to everywhere is there is new definition of PPH in 2025 update. What is that? Previously, we were telling any vaginal delivery, if the bleeding is more than 500 ml, or if the cesarean section bleeding more than 1000 is PPH. Now, any blood loss more than 300 ml with warning signs. What are they? Atonic uterus, heavy blood loss, large clots or constant trickle of blood, change in the vitals. And this is very, very important. Everybody should watch for this. If the pulse is more than 100 beats per minute, systolic blood pressure less than 100 millimeters of mercury, diastolic less than 60, and shock index more than 1. Normal shock index is at 0.5 to 0.7. That is heart rate by systolic blood pressure. Means the patient is going in shock, attend immediately. This is the warning sign. If more than 300 ml with all these things, or if the blood loss is more than 500 ml, even if the women has got no other warning signs, this is called the PPH. I think I made it clear, everybody. Especially for the youngsters, it's very important to understand. At this time, for this FIGO WHO call Action 2025, every facility, means wherever the women takes her birth, delivers, it should be equipped and trained. That is, the India's mission is 80% of the cases must be institutional deliveries. I think we have achieved. Most of the people are delivering in the institutes nowadays, and every birth should receive active management of the third stage of labor to prevent PPH. That is, the giving uterotonic is very important. I'll just come to all these things. And every woman should survive without preventable morbidity. You know, mortality is one, means behind that morbidity is 10. That is why the morbidity should be prevented for this. So global roadmap is here, end PPH by 2030. PPH is all about time taken. How you have to recognize, act in time, and to escalate. Be vigilant for early warning signs, early diagnosis, quick response, and prompt treatment with the PPH bundle is very, very important. That is going to solve the PPH deaths. So, what are the 6 pillars of our PPH care? 1, give uterotonic. This I'll explain afterwards. Place the blood measurement tool. That's very important. This is the blood measurement tool, and deliver placenta with controlled contraction and countertraction. Check uterine tone and massage if soft only. Check bleeding, monitor every 15 minutes. This is what is very important. One more thing I want to add is slow delivery of the trunk when delivering the baby. It's very important. And the head has come out, don't pull the baby like that. Once you pull, it is going to, if the placenta is not separated fully, and there is no time for the uterus to contract and retract, that is the time it bleeds more. So give time for the uterus to contract. That's why it is the slow delivery of the trunk is very important. But you have to recognize the risk factors and act. So prevention of the PPH is very important. What are the risk factors? Previous PPH, twins, prolonged labor, preeclampsia, infection, uterus refuses to contract, retained placenta, yes, some foreign body present in the uterus, it will not retract, augmented labor, history of severe anemia, if there, you should be more vigilant. Identify high risk factors for PPH in every case. Remember, PPH does not exempt anyone. So everything is normal, antenatal, before delivery, anything is normal. Suddenly, patient can go in for PPH without warning signs. So vigilant for every case, 100% you should be vigilant for that one. So how are we going to manage? One by one, we will take you uterotonic within 1 minute. So this is check for second baby first, and then do the active management of the third stage of labor. What is this active management of third stage labor? All of the seniors, if you remember, previously prophylactic methogen we used to give at the presence of anterior shoulder thing. Now it has gone active management. Here the prevention starts immediately after the delivery within 1 minute. So give uterotonic. What are you going to give? 10 international units IM or IV oxytocin. If already IV is present for every case, it is better to start one IV lifeline and then give IV if it is possible. Dilute it in 10 units, dilute it in 2 ml, and then give slowly over a period of 1 to 2 minutes. And whenever we use oxytocin, it should be refrigerated, because when we did duties, sometimes it never used to work. Why? In summer, they used to keep the ampoules outside, so they never used to work. That is why it is very important to see that oxytocin is kept in the refrigerator at 2 to 8 degrees temperature. And next is carbetocin and heat stable carbetocin. Two things are there. In heat stable carbetocin need not be refrigerated, but other carbetocin should be kept at 2 to 8 degrees centigrade. If IV administered slowly over 1 minute, and heat stable carbetocin, no refrigeration is needed. And the another important thing which we can use is the misoprostol, which we are using regularly. Not carbetocin regularly we are not using, but misoprostol S, 400 to 600 micrograms orally or sublingually or per rectal. And all of us should know what each tablet is, how many micrograms, and each ampule of oxytocin contains how much. So this is very, very important when we are prescribing. High risk for PPH cases, if it is present, combine oxytocin with misoprostol or carbetocin with misoprostol. Both can be combined. 90% of the times, blood loss is underestimated. I think all of you agree with me. We'll do episiotomy and we'll go and deliver some other patient, or we'll wait for the linen to be changed and come. By that time, the blood will be trickling and trickling. Always we underestimate the blood loss, and only next day when you see, the patient will be anemic. So estimation is very, very important. That is why we should have a calibrated bag to check how much of blood loss is present. Second thing is place the tool for measuring blood loss. This is what is the calibrated bag. We keep it, and it is mandatory. It's very cheap also. It's not drapes with a calibrated funnel, or it can be trays with calibrated lines or other innovations, whatever it is. We should check the blood loss. That's all. Sweep blood and clots into the tool. Continuously check how much bleeding is there. Amount of blood in the tool is very, very important. And dangerous bleeding, if it is present, even though it is slow, steady stream or large gush that is present, please watch and do the needful. For early diagnosis, objective measurement of blood loss is the key. Otherwise, we always obstetricians underestimate the blood loss. We say, no, there's not much blood loss. Only in the morning when the hemoglobin is 5 or 6 grams, then we know that there was a lot of bleeding that was present. The third thing is wait for 1 to 3 minutes to cut the cord. There is no hurry. Immediately once the baby comes, there is no need to cut the cord immediately. Only if it is indicated, like premature baby or RH negative mother, baby is not breathing well, then only you cut. Otherwise, you take time until the pulsations stop. You wait so that you will give time for the uterus to retract and deliver the placenta spontaneously. And cord and counter traction only by skilled health worker. This you should remember. You should know. I mean, it need not be a doctor. Even the health worker should know how to deliver the cord by traction and counter traction method. And when do you deliver the placenta? It is only the after placental separation. Don't pull the cord when it is not separated. How do you know that the placenta is separated? That is, extra vulval lengthening of the cord will be there, or a gush of blood will come before separation of the placenta. That time you apply the cord traction and then pull. What is that counter traction method? You put your left hand onto the abdomen, so that while pulling the placenta, along with the placenta, the uterus will not come, and involution you are going to prevent that one. So if there is any resistance, or if it is not coming out, you wait for some time. Don't unnecessarily pull it, and that will lead to the tearing of the cord and uterine inversion. You wait for some time and then you try to do it. So the next thing what you should do is, already your hand is on the abdomen. You check the tone and massage only if it is soft. The nature of the placenta is my uterus is, once the placenta is separated, automatically it contracts and retracts. The uterine muscle, the middle layer of the uterine muscle, the crisscross fibers will be present. That is the living ligatures. The blood vessels will pass through those ligatures and it retracts automatically, it stops bleeding. That is the nature's gift to the uterus, and that is only possible when the uterus retracts. So keep your hand onto the abdomen and see whether the uterus is soft, firm or not, or in the midline, or usually it should be below the level of the umbilicus. If these are not there, if soft uterus, if it is present, if it is not in the midline or to the side or above the umbilicus, think that the bleeding is occurring inside. If the fundus rises, is off to the side or becomes soft again, think it may be full of clots or the bladder may be full. So if the uterus is soft, massage, encourage frequent urination. This is what is very important. Check the uterus at least every 15 minutes for the first hour. Means if the retracted uterus only, you will check every 15 minutes. Otherwise, immediately you should start action. Remember, always IV line and prepare a uterotonic 2 hours before the delivery itself. Oxytocin and misoprostol for prevention and treatment, but carbitocin is only for prevention and it is not for treatment of the PPH. We repeat, women at high risk of PPH give combination of oxytocin IM or IV and misoprostol 600 micrograms oral, sublingual or rectal, and tranexamic acid, injectable prostaglandin or ergometrin, and combination of these things for treatment only. You should never use it for prevention. Ergometrin is out of this thing. Nowadays, we don't use ergometrin at all. But if it is intractable PPH only, we'll use the ergometrin. That is not there. Just excuse me 1 minute. I'm so sorry. So this is to repeat again. You have to give prevention. We can use oxytocin and misoprostol. We can use carbitocin also, but tranexamic acid if the bleeding is more, and ergometrin if bleeding is more, not for prevention of PPH. And the fifth one is check for the bleeding. If bleeding is more than 300 ml blood loss or warning signs such as already I told you, atonic uterus, heavy blood flow, large clots or constant trickle if it is present, or if it is more than 500 ml, stop PPH bundle and alert the your staff. So what are the monitoring? How are we going to do? BP, pulse, and I mean, symptom index that is there or shock index after the delivery of the placenta or 15 minutes after the birth. And first of all, what you should do is put your left hand onto the uterus constantly and see for the uterine tone, specifically for the high risk patients. Volume of blood loss and flow using the measuring tool, blood pressure, pulse. These are all repetitions, but still, why it is being told is this message should go to the newborn corner. They should never forget. That is why these are the repetitions that are present. WHO, and this is the manual that is prepared by Daksharda Jain, so that it will not once, twice, thrice, 10 times if we read, it will enter into our minds. So what are the warning signs? Already I told you, it is the pulse rate more than 100, systolic blood pressure less than 100, and diastolic blood pressure less than 60. Monitor every 15 minutes for the first hour, then every 30 minutes for the second hour. And the next very important thing is empty the bladder and repeat. Mean all these things should go simultaneously, not one after the other. All the PPH treatment is a simultaneous one. So empty the bladder and repeat controlled contraction and countertraction if it is not delivered previously. And third, very, very important thing is the placenta after treatment, when it comes out, you please keep it in your hand, both the hands, and then see whether it is complete or not. If the placenta has not delivered, then you call for the help. Don't go on trying if the bleeding is present. So once the placenta is delivered, check placenta for completeness. Put your two hands like this and then put the placenta in this one and see whether all the cotyledons are complete. Any missing cotyledon is there, or the membranes, if they are complete or not. If any, remove manually. If uterus is formed, placenta is complete, but bleeding is there, think it is a tears that is present. 70% of the times, PPH is because of the atonic uterus. If the uterus is retracted very well, the bleeding is present, think that there is a tear. Look and assess for the tears and repair. If PPH is present, start treating. That is the PPH bundle we have to start. I will tell you what is the PPH bundle. If bleeding normal and uterus is hard, assess the baby. That is, there comes the mission new. That is the neonatal early recognition and treatment. Check the color, temperature, breathing, and record on the newborn chart. Start skin to skin and encourage breastfeeding. Within 10 minutes, they should start breastfeeding the baby. Assess the women. Check uterine tone, blood loss, flow, pulse, and blood pressure. Record on the postpartum monitoring form. That's very important. Always, it is better to engage the women to prevent PPH, means to treat her. You should teach her how to inform the things. She should not take it for granted that if the bleeding is present, it is normal. She should inform the attender, whoever is present. If the bleeding is more, or if the reeling sensation is present, she should call for help and tell. After 1 hour, if stable and no bleeding, remove the blood loss measurement jar that is there. Then only you shift her to the postnatal ward. If PPH is there, start treatment for the treatment bundle and immediately. So, for early diagnosis, first and foremost, be alert. Identify high risk factors, if any. The next step is assess the uterus tone, flow and amount of blood in the measuring jar, pulse, BP, and shock index, and early warning signs, if they are present, you should see. That is the atonic uterus, heavy blood loss, large clots, change in the vital signs. You should be very, very careful. This is again and again repetition of what it is. So, to say, within 1 minute, you are going to give the uterotonic after delivery of the baby, oxytocin 10 international units IM or IV, or carbetocin, and or misoprostol 400 to 600 micrograms. Start measuring the blood loss. Cut the cord between 1 to 3 minutes. Whenever you are cutting the cord, during the uterine contraction only, you deliver the placenta and then cut the cord. So this is again is the same. The mission give, that is after delivery, how are we going to take care of the baby? This is prevention of PPH. Still, if it is not controlled, how are we going to treat the PPH? So call for the help. This is very important. Never think that you are going to tackle everything alone. Loudly you call for help. Need not be doctor, whoever is present, either nurse, paramedical, fourth class, whatever it is, call them for emergency equipment and medication. Assess for shock, communicate with the people, start the treatment bundle. Treatment bundle is set of interventions that, when given together, improves the outcome. So we have a mnemonic for the treatment bundle, that is motive. Yam is, if the uterus is soft, you massage the uterus, give oxytocin to uterotonic drug and tranexamic acid and IV access and IV fluids, and examine to find the cause of bleeding. E is for examination and escalate the care. Do it immediately, escalate the care. This is the PPH bundle that is there. Motive. M is for massage, O oxytocin, T tranexamic acid, IV fluids, and examine for the cause of bleeding and then escalate the care of the patient. So the oxytocin is better for treating the case. 10 international units IV diluted in 100 to 500 ml of crystalloid, that is ringalactate, you can take as fast as possible. Preferable to avoid hypotension, or as bolus dose over 1 to 2 minutes. If no IV line, give oxytocin 10 units IM or misoprostol 800 milligrams, micrograms oral. Tranexamic acid is very important. I told you, everybody should know when they are giving some medicine, they should know how much is the medicine in that one, how many ampoules we should give, and whether to dilute it or not, IM to give or IV to give. This is what is very important. Tranexamic acid, each ampoule is 5 ml, and it has got the 500 milligrams of tranexamic acid. We have to give 1 gram IV over 10 minutes, means it is the 2 ampoules you have to dilute and give it slowly over a period of 1 to 2 minutes, because faster administration can cause hypotension. Tranexamic acid and oxytocin can be given in the same line. Everybody will have the idea whether we can give it immediately or not. Yes, you can give in the same line, but don't mix them in the bottle, but that is there. Don't mix. If you are giving oxytocin, okay, give only oxytocin. You can give in the same line tranexamic acid, but don't mix both of them in the same bottle. If 3 hours or more since birth, don't give tranexamic acid. If there is a contraindication like hypersensitivity, known thromboembolic events, renal failure, or a history of cough, anything is present, please don't give tranexamic acid. In that period, maybe it is very difficult to make out. We do give it, and then most of the times we will try to see before itself, we will take the history. Because I already told you, PPH will come unintimated. We will not know which patient goes into PPH. So taking a history properly, examination of the patient, everything is important, and get prepared every time to face the PPH in every patient. That's what is very necessary. Once you start IV, as quickly as possible, you ceased any patient. I told you, whoever comes to the labor room, better to have a IV line with them with 18 gauge cannula and largest needle. And whoever is working in the labor room should know what is the gauge of needle and what is the color code that is present for them. 18 gauge, 16 gauge, 24 gauge, everything has got a color code, and keep them. A white bore needle is always preferable. Bigger infusions of crystalloid fluids only, don't give colloids. And if clinically indicated, insert second IV line with crystalloid solutions. Examine to find out the cause. And I told you, 80% of the cases, it is atonic PPH is very, very common. If the uterus is retracted, still bleeding is present, then you think that there is a tear that is there. And tissue is 20%, trauma accounts for 10%, and thrombin accounts only 1%. But what is the major cause? It is the atonic is the major cause of bleeding. Madam Sharda Jain, madam, good afternoon. and examine to find the cause. This is what is very important. You first see whether the uterus is retracted or not. If the uterus is retracted, the cause is some other thing, that is the tear may be present. If the tone is not, if it is, the uterus is soft, massage it with, because already your hand is one hand, left hand is already on the abdomen, suprapubic, to see how the uterus, whether it is retracted or not. With that, you give the massage if it is soft only. Otherwise, there is no need to go on massaging. Assess whether there is a full bladder. You have taken 2 hours or 3 hours after delivery and giving IV fluids one side, and if the bladder is full, definitely it is not going to retract. So you can put the indwelling catheter under all aseptic conditions. That's very important. And once you insert the catheter, you keep it. Don't remove it. Go on putting one and removing it one. Put it until you finish all your job. And see, inspect the placenta between your hands for any missing lobes, because there can be small pieces of the membranes can be present. That itself also bleeds. If the placenta is adherent, if it is not coming out, don't go on pulling there. You may cause the inversion of the uterus. If you suspect accrete or anything, surgery is needed. Better you shift the patient and check them for the perineal tears, vaginal tears, cervical tears, and repair it. If the uterus is retracted hard and still if there is bleeding, you think it is because of the tears that is happening. And if the patient needs no bleeding, but still if she goes in for shock, think of inversion. Don't forget it. And the hand is already on the abdomen. You see that there is something lacking. The uterus is not present. That itself says that something is not there. That is the inversion of the uterus is there. Replace and follow the local protocols. I am not going to tell about the inversion of uterus. If suspect uterine rupture, seek advanced care. Normal delivery, it's very rare to get the rupture unless it is the previous cesarean section and all. And thrombin coagulopathies, you think there's only 1%, but still always keep it in mind. Collect blood for testing, like in hemoglobin, cross-matching, blood grouping, prothrombin type. Always be ready for everything. Collect all these things for coagulopathy and see. The last E is motive is also for where you escalating all these things simultaneously. You do it and do at a escalating care quickly. If bleeding is heavy while giving the bundle or continuous after bundle is complete or more than 1000 ml at any time. If a woman has extensive trauma or has uterine inversion or hypotensive or unresponsive, if unable to identify and manage the case, act fast. How you are going to act? You shift the patient to a place where all the facilities are available. If facilities are available, you are in the institute, shifted to the theater where you will get the help from the anesthetist and you can maintain the blood pressure. Call for more help for seniors, continuous monitoring, call for the anesthetist, communicate. That's what is very important. And I already told you, catheterize, you have put the catheter, don't remove it. Remove clots from the cervix and uterus. And all of us, you should be well versed to suture the tears, cervical tear suturing, vaginal tear suturing, or fornical tear suturing. First of all, you decide whether you can manage in the labor room or not. If you cannot manage, shift it to theater where the light is available under all good conditions. Only you try to do it. Don't go on doing and lose the patient. No, that's not the correct. You pack it and take it to the theater where all the facilities are available under good light, under all lithotomy position, everything is available, then only you do it. If okay, if you are in the institute, you are going to do with all these things. If you are in a rural area where theater facilities are not available, what are we going to do it? If needed, arrange to transfer for surgery, apply non-pneumatic when surgical bundle if shock or risk of shock. Prepare for blood transfusions, give a single dose of antibiotics that time. So simply giving antibiotics is not necessary. Whenever it is necessary, only you have to give. So what are you going to do it? That time, already in the beginning itself, it's not one IV line is there and second IV line also you start. Give additional uterotonics. What uterotonics you are going to give? Either in oxytocin you already given. If the uterus is retracted, there is no point in giving the uterotonics. Only thing is put 5 to 10 units of IV into the IV line and make it go. That is 20 units of in 1 liter of crystalloid solution. Do not give more than 3 liters of IV fluids with oxytocin in 24 hours. Please remember this. And maximum 60 international units in 24 hours. And ergometrin tartrate, that is it is a fixed dose point, that is 200 micrograms IV or IM in 15 minutes if needed. Repeat every 4 hours for 5 doses. Again and again, I review ergometry. We are not using nowadays as prophylaxis because it produces, if inadvertently, if you give it, hypotension can be present, but it is only in intractable PPH. Under your care, you can give the ergometrin. Previously, we were giving ergometrin for the prevention of the anterior shoulder and all. That has gone. That's why I told you WHO is doing again and again so many manipulations, is only to see that no mother dies of PPH, to prevent the maternal mortality. Do not use either if suspected retained placenta or if hypertension cannot be ruled out. So that's what I told you. And misoprostol 800 milligrams. Again, to repeat, 1 tablet of misoprostol is 200 micrograms. Now 600 micrograms tablet also is available. You can use it either sublingual or per rectum. And tranexamic acid also can repeat it second dose, 1 gram IV over 10 minutes. So again, to repeat, everybody should know what ampule they are giving. Each ampule of tranexamic acid is 0.5 grams, and that is 5 ml. And here 1 gram you have to give means 2 ampules slowly over a period of 5 minutes you have to give. Give if bleeding continues more than 30 minutes after first or resultant within 24 hours after that first dose. Assess and record every 15 minutes or more often until the tone, blood loss and flow, pulse and BP. Assess for shock. Shock index, I already told you. If shock is there, ABC and manage. If needed, arrange for transfer surgery. Apply for non-pneumatic anti-shock garment. This everybody should know. It is very easy to apply. And start from the numbers are given 1, 2, 3, 4. And how are we going to manage and prepare for blood transfusions? So advanced intervention completed with PPH bundle. So what are you going to do? Call for more help, assign tasks instead of 2-second IV and give extra doses of medications. Repair tears, remove the placenta and clots and see for any tissues are left behind. Apply non-pneumatic anti-shock garments if available. Even now, if bleeding continues, consider more than one cause of bleeding, uterine rupture, or especially for augmented labor or prior cesarean section, and deep vaginal cervical lacerations if they are present. So, with these things, this is very, very easy non-pneumatic surgical garment to use it. You should learn how to use and then we should shift. And what are all the advanced interventions? Just already I told. To finish that one, what are you going to start? Safe blood transfusion. If the hemoglobin is less than 7 or she looks anemic clinically, start with the blood transfusion. And if the tear is present, I told you we should learn how to repair the tears, because cervical tear repairing is an art. You go to the apex of the tear, suture first. Otherwise, if you leave it to, there's no point in doing either vaginal tear or the cervical tear. And apply bimanual or aortic compression. This is another one, very simple, but everybody should learn. Aorta is onto the left of the umbilicus. If the patient is thin, many a times normal patient, when she comes to the gynec exam, you try to palpate and see that you can see the pulsations of the aorta. You try to, with the fist, you try to obliterate the aorta, and at the same time see that the femoral artery stops bleeding if the aorta is compressed. Or you can apply uterine balloon tamponade also. See, this is the uterine balloon tamponade that is there. Put it inside and inflate it. Because of the pressure, the bleeding stops. Then you apply the non-pneumatic anti-shockment garment and then shift her to the thing. And before shifting, the one more thing we can do, it is within our reach, is the bimanual compressions. It's very easy. Once you see, you will not forget. Always your left hand onto the abdomen and put your left hand behind the uterus and right hand fist. Put it into the anterophonics and compress the uterus between the two hands. That's very important until the bleeding stops. Usually, if there is no foreign body like placenta or the membranes, if it is only hypotonic uterus, it retracts very well by this bimanual compression. So massage the uterus and after 5 minutes, you see, slowly remove the hand. If bleeding restarts, resume compression. If no bleeding, continue with the IV infusion. And this is what I told is the compression of abdominal aorta. Apply downward pressure with closed fist over abdominal aorta through abdominal wall. With other hand, palpate femoral pulse to check adequately compressed or not. If pulse is palpable, it is inadequate compression. Pulse not palpable, it is adequate compression. Maintain compression until bleeding is controlled or until she reaches the operation theater. These are all the when first aid measurements we should do it. Check and remove any retained clots. Repetition. Though repetition is there again, it is only to remember things. So I consider aortic compression before insertion. Check and remove any retained clots of tissues. Ensure deep tears and repair. Ensure empty bladder, monitor blood loss. If still bleeding after 15 minutes, seek for surgical help. So first 15, 20, these are all the things, quick action. That's what is the PPH bundle, quick action. Do it everything in 15 to 20 minutes. Identify and repair vaginal wall and cervical tears. Bleeding from a tear may be slow, heavy, or spot an artery. Seek advanced care. If repair does not stop bleeding, surgery may be required. That's what I told. Every delivery should be institutional. We could achieve now 80 to 90% of the deliveries are institutional, and every place where delivery is conducted should be well equipped with for cesarean section and for managing the PPH. That's what this is. What is the non-human bags to stop the shock bag that is there. This is 1, 2, 3, 4, 5, 6. Here, no time for me to demonstrate all these things, but it's very easy. Always we should learn on the patient. The lower body compression device made of stretch neoprene, which closes tightly with Velcro in segments for the ankles, calves, thighs, pelvis, and abdomen, and is applied rapidly starting at the ankles. If force, uh, it forces blood to the heart,
मैडम थोड़ा
lungs,
क्विक
and
भी
brain
चाहिए होगा
to
हल्का सा
prevent.
राइट लिटिल बी क्विक
Yes, madam, I am prepared.
ओके
Finish,
ओके
madam.
ओके
2 more
ओके
minutes.
ओके ओके
What we should understand here is this anti-shock government does not treat PPH, but gives time to seek treatment. It's only two things. Then comes the surgical interventions. Our main aim here to prevent atonic PPH. So surgical wise, this is not the time to but uterine compression, step-wise devasculation, internal iliac ligation. These are all the emergency theater measures. We need not know all these things, but only thing is when to shift is very, very important. Monitor closely until stable, and when becomes stable, then only you shift her to the ward. Until that time, no. Remember, administer all interventions, even if the women improves, the order does not matter. PPH bundles are to control and manage atonic PPH. So the golden hour is important. First 15 minutes, 15 to 20 minutes is for the medical management. and 20 minutes is the uterine techniques, what we are going to do in the labor room, and remaining things is the surgical procedure. This is what is the thing. So then if you cannot, then you transfer the patient to higher center where you stabilize,
Hello.
temporize, and transfer these things. So recording is very important, medical legal aspects, time of onset of PPH, sequence of events, and the time of surgical interventions, the condition of the mother throughout, we have to monitor. At the time of discharge, please don't forget to write what are all the things you did so that next time when she comes for delivery, they will know, because previous PPH is one of the high risk factors for the PPH in the again, so that they will take care of the things. So plan follow up care for 48 hours, 10 days or 6 weeks. Final take home message. Prevention is the backbone. Identify high risk factors, antenatal optimization, control blood pressure, anemia, and all. Earlier diagnosis saves lives, and recognize early warning signs. Objective measurement of the blood loss is now mandatory. Don't think that she has not bled only because always we underestimate as obstetricians. So golden hour management is very, very important. And again, I thank all the Dakshada Jain and team for giving me the opportunity, and such a wonderful message, madam. You are giving it to the all nook and corner of India. And if they follow, definitely we will able to control PPH in 99% of the cases. So only thing is we should be able to teach the students. Thank you very much again for giving me the opportunity.
Stop sharing, ma'am. हाँ बस ठीक है. Thank you. What a wonderful, what a great talk today. It was amazing, madam, really amazing. And Dr. Sharda Jan madam was here. She was here for some time. I don't think now she is there. So let us wait for her to say few things. And in the meantime, madam, this please accept this small token of appreciation from Dr. Sharda Jan madam, and these are like her blessings only. And please accept it. Thank you, ma'am.
Thank you. Thank you very much, Dr. Archana. I am blessed to
Thank you,
receive
ma'am.
this
Thank
honor.
you.
Thank you
ऑनर
very
मैम,
much.
आपने सब कुछ बहुत डिटेल में बताया. आई थिंक एवरीथिंग यू वॉट एवर इज नॉट रिटन ऑल्सो यू हैव फोकस्ड एज अ सीनियर टीचर विद योर एक्सपीरियंसेस एग्जैक्टली वेयर वी शुड डू. एंड I don't have to add any line after your talk.
Thank
I
you.
was
Thank
rather
you.
worried. That's why I was saying कि maybe Dr. Sharda Jain is here. So because she was very busy, so I thought कि maybe she could say something, because she must have wanting to talk to you also for some time.
Dr. Archana, if you give time, I can ask that Sarojini Devi
Yes,
madam
madam.
to
Yes, no, madam.
uh,
Madam,
uh,
that's what I was saying.
and
Yeah,
Dr.
let's ask
Satyavati to
her.
comment.
Please, please
You are
ask her.
muted, madam.
Please
Both
ask
Madam
her.
Sarojini and Satyavati, you are muted.
Hello,
Satyavati
Ambuja.
madam.
Hello,
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 madam.
Satyavati.
Ambuja. Satyavati here. Very nice lecture, Ambuja. I remember our days together when we worked. And you have taken me back to the labor rooms of our government hospitals, where we ran, struggled, and saved so many patients from PPH. And really, it is an excellent lecture and excellent experience for me, because I went back to the 20, 30 years back when we were in the labor room without much and calling you, me, and everybody, running, taking blood, giving massages, and how we used to save many number of PPH cases even in with minimal advantages. So thank you, Ambuja, for this excellent
Thank
lecture.
you, Madam Satyavati, madam. Madam is my mentor. I worked with her for 9 years, and I'll tell I learned, teach, and everything from Madam. Thank you very much, Satyavati, madam.
Thanks, Ambuja, for your comments. Thank you. And really, it is remembering back my days in the hospital. Very nice.
Thank you.
Thank
Thank
you,
you,
madam.
madam.
We are honored to have your blessings here. And madam is so senior. Dr. Ambuja is herself so senior, so her mentor must be, I mean, very.
Yes,
Madam, they are
I'm
all
more
very
senior.
perfect, madam. More than anything, perfect. That's what I can say. They used to do perfectly. And because of them only we are here today.
Oh, thanks, Ambuja. Thank you.
मैडम
We
यही
all work
डॉक्टर
together.
अंबुजा यही मैं
Madam,
आई वांट
one
टू
thing
से
I can say that the teamwork, as she said, call back all the people, let us all together put together our efforts. And I think we can avoid many number of PPH deaths because one going for blood, another doing massage, another starting IV. Then these things I still remember how we used to work 20, 30 years back. I retired 20 years back. So you can imagine how senior. So those days we used to work very hard, and all of us, irrespective of the unit, irrespective of the thing,
Cadre.
government hospital, we used to work together. That's what I remember. Thank you very
Thank
much.
you, madam. Thank you very much.
Ma'am, those were the days. Even I started my PG in 83. So 1983. So I can still say that Taru is also of the same batch. So what we used to run, and we used to respect our senior a lot. एक अगर senior ने कह दिया एक टांग पे खड़े रहो यहाँ इस patient के पास, तो अब क्या ही कोई shock index अब का जमाने में देखेगा, हम 6-6 घंटे वहीं patient के पास ही खड़े रहते थे. So
That's true.
and the respectful maintenance.
Thank you, Dr. Ambuja. Thank you
Yes,
very much.
madam.
True, madam. That
Thank
is
you very
true.
much.
Madam
then one or
Sarojini
two
Devi,
points
madam, is a
I
very senior
learned.
mentor of
I
ours,
know.
and she's retired director of medical sciences of Andhra Pradesh. Madam, your kind words, madam.
Thank you. When we were there as students, Dr. Subhadra Devi was our chief. So she always says, after delivery, immediately turn the patient to the left side.
Yeah, yes,
Then,
madam. I forgot to tell. That is one of the things. Yes.
see, that is a very important point because
Yes.
even if the placenta is not delivered, left lateral position will kink the uterus and then stop any bleeding. So that is one practical
Yes,
point I
madam.
wanted to.
Another thing is easily we'll be able to palpate the uterus. That's the main reason. Otherwise, a heavy uterus falls back. We will not be able to
Ah,
make out the tone of the uterus. That is why the lateral position keeping is very, very
yes,
important. It
Yes,
went
that
off
is
my
true.
mind,
We
but that's
always
one
used
of
to
the
do that.
things. Yeah, we used to do
lateral is
it.
better than dorsal.
Yeah, dorsal position.
Hmm.
Put it in the lateral position so that you'll feel the tone of the uterus. Yes, madam. Thanks for
Thank you.
reminding us that that's one of the practical points.
Thank you.
Thank you
Thank you
very
very much.
much, madam.
Thank you.
थैंक यू मैम. दिस इज वेरी नाइस टू अंडरस्टैंड कि ये पॉइंट तो हम लोग हमेशा ही भूल जाते हैं कि it is easy to palpate also, and patient will also have comfortable.
Yeah, patient
Oxygenation will
also
be
feels
better.
very comfortable. Yeah. And bleeding also will be less in the left lateral position.
Uska, what is the reason for that?
Madam,
Because the
heavy
uterus,
uterus, when it is there, falls backwards. And so the blood flow also will be more in that position. If if it falls reverse, and then if you give massage, the uterus retracts.
in that position, the uterus
And
falls to
definitely
one
cardiac
side.
overload is less, and even the effects of the methodine, everything is less in the left lateral position, and the oxygenation and the blood circulation is much
Yeah.
Madam
better.
Sarojini, madam, you wanted to tell something else, madam?
That uterus is kinked to one side so that automatically some blood loss will be prevented.
Yeah.
That's what I want to say. And
Yes,
then don't
madam.
keep the patient in lithotomy position after delivery. Immediately turn her to one side and
To
see
this
for
side.
separation of placental
Yes.
sign, and then remove the placenta slowly.
Yes, madam.
Then look for any tears immediately. If there is still bleeding, look for any tears. Our madam used to say, put a speculum if you can't locate, and then immediately suture it. Otherwise,
Yes,
he'll be
madam.
going on bleeding in the ward.
Bleeding.
Ma'am,
Yes,
is
madam.
there any role of left lateral position in separation of placenta as well?
No, we can separate. We can pull out the placenta. See
If
whether
there
the
is,
uterus
if it is
fundus
bleeding,
is rising.
Dr. Taru,
Rising.
if it is bleeding, left lateral position. If it is uterus retracted well and no bleeding, definitely in the supine position, we can remove the placenta.
In that left lateral position, uterus will be kinked to one side, so that automatically vessels will be compressed, like
Yeah.
twisted. So
Yes.
blood loss
supply,
will be blood loss will be less.
uterine kinking will be there.
Oh.
Thank you very much, madam.
So overall, take home message is कि do not leave patient just after the delivery. You have to watch for some few hours, definitely. And assessment in time is very important. Call for the team and emergency management. If it is not possible by you to manage, then early referral is important to a higher center with a proper documentation and note. And also talking to the
No.
center people whom you are sending the patient.
Because what I want to say, I think जो so-called management है वो all gynecologists think that they know, but the only thing to make them aware is that to know that what exactly is थोड़ा छोटा सा take home messages जो होते हैं जो tips होते हैं they always help. आजकल जैसे even previous LSCS को even if the ultrasound is saying placenta is normal, you should take it एक mind में अपने आप से high risk रखो, it can be adhered also at that time. And that is there are certain things उसके लिए आपको टीम प्रिपरेशन और बर्थ प्रिपेयर्डनेस ये सब जो छोटे छोटे पॉइंट है ना वो गिन के वही है कि रिमेंबर द पीपीएच इज ड्रामेटिक, जब आप उसको सोच भी नहीं रहे होगे वो तब आएगा. एंड देन लो रिस्क कैन ऑल्सो हैव एक्ट फास्ट एंड एक्ट राइट, आपको बहुत ज्यादा भी नहीं देना है बहुत कम भी नहीं देना है. एंड प्रिवेंशन इन द गोल्डन मिनट इज ठीक है, और उसके लिए आपको 2 घंटे पहले से ही तैयारी करनी पड़ेगी. आईवी लाइन आते ही मेंटेन कर लेना चाहिए, जितना भी जो भी आपका ना सिस्टम है ना वो सिस्टम जो मैडम ने अभी कहा सत्यवती मैडम ने कि टीम वर्क मैटर्स, तो वो टीम का
Yes,
ही
yes,
हर जगह ही है. एवरीवेयर द टीम मैटर्स. जैसे अगर हमारी टीम
yes,
नहीं
sir.
होगी तो हम कुछ काम नहीं कर पाएंगे अकेले, और हम ये सोचेंगे
Yes,
हम
sir.
सारा क्रेडिट हम ही लेके खा के मर चले
It's like,
तो वो भी
no, madam. It is not the credit that we want. It is the
हाँ,
patient that.
it is for the sake of
As
the
Ambuja
patient, for
said,
the
it is not
society.
to look for whether it is a junior or senior or anybody, nurse
Senior.
or
Yes.
everybody who must come and then take the responsibility. That's all.
Yes,
Not to
yes, yes. And
feel egoistic
yes,
in case
yes,
of
yes, yes, मैडम.
it is-
हाँ, होता है ना मैडम कभी कभी जिसमें आप बहुत सोच रहे हो कि इवन डीएनसी में भी सोचते हैं कि ये तो 2 मिनट में निपटा लेंगे, उसी में बहुत टाइम लग जाता है. So with वो you know, and the for the prevention part, all keep 3 things ready. One thing is IV line, then IV fluid, and then loaded uterotonics.
Yes, ma'am. Yes.
Yes.
जैसे हाँ, आपके पास अगर इमरजेंसी में जैसे गन है ना लोडेड नहीं होगी तो आप चला नहीं पाओगे, जब तक आप लोड करोगे वो तो इम्पोर्टेंट सा टाइम वो मोमेंट निकल जाता है. एंड फर्स्ट एंड मोस्ट पावरफुल स्टेप इज AMTSL. तो जो लोग बहुत जो आजकल की न्यू जनरेशन है वो बड़ी बड़ी बातें करने में ज्यादा इंटरेस्ट दिखाते हैं, वो उनको AMTSL तो ऐसा लगता है कि बस हमें तो आता ही है, हर चीज आती है. बट AMTSL पे बी स्टिक टू बेसिक इज वेरी इंपॉर्टेंट.
Yes, ma'am. Yes, ma'am. Every patient you have to be a learner. That's all.
लर्नर, एवरी
Yes.
पेशेंट यू हैव टू बी लर्नर. और
Yes.
हर पेशेंट मैडम सिखा के भी जाता है, हर पेशेंट चाहे
Yeah, madam. We
उसका
learn things.
बिहेवियर आपको सिखा के जाएगा या उसका टाइम इंपॉर्टेंट एनीथिंग, मतलब आप हर पेशेंट से डेफिनेटली कुछ ना कुछ सीखते हैं. जैसे आज हम लोग सीखा मैडम कितना, अंबुजा मैडम इतनी सीनियर है बट शी इज गिविंग सो मच रिस्पेक्ट टू हर मेंटोर्स, तो ये आज नंबर 1 पे सीखने की बात है.
Madam,
Nice,
we are here
nice,
only
madam.
because of them, madam. They taught us. How can we forget whatever is the thing is only Madam Sarchandrika madam, Sarojini Devi madam, Satyavati madam, they are all our mentors. They taught us each and
यस,
everything.
मतलब ये आदमी को कुछ चीजों को तो भूलना ही नहीं चाहिए. ये इसका आपका
भूलना
मतलब
नहीं
ये मुझे बहुत
चाहिए।
बहुत सही लगा कि जिसने आपके लिए कुछ किया है या कोई हमेशा करा है और रेस्पेक्टफुल उसके लिए तो आपको रहना ही पड़ेगा, और उसको भी सीनियर को भी और जूनियर को भी थोड़ा थोड़ा कहीं ना
Yes,
कहीं
madam, you are
उसको
correct.
You are true, madam. True.
और मैडम एक जो आपने सबसे शुरू में बोला अंबुजा मैडम, वो वैसे तो सुनते हैं हम हर बार हैं, बट मैं फिर भी मतलब एक बार चलते चलते फिर बोलना चाहूंगी. गुरुर ब्रह्मा गुरुर विष्णु गुरुर देव महेश्वर गुरुर साक्षात परम ब्रह्म तस्मै
Tasmai
श्री
Sri
गुरुवे
Guruve
नमः.
Thank
Namaha.
you, Gurave Namaha. Gurave
Yeah.
Namaha.
गुरुवे नमः. तो मैडम आपसे हम लोग अगर कभी हमारी खुशनसीबी रही हम हैदराबाद आए तो सत्यवती मैडम से और सरोज मैडम
तुम
से
आके
और
ना
सबसे
You can stay with me. We can spend time. You are welcome, madam. Welcome.
Done, madam.
Welcome.
Done, madam. Done. So,
Thank you.
Dr.
It is
Tarun,
very
Thank
nice
you,
to see you
Archana.
all, meet all of you,
आज
all of
मैडम
you.
आज वैसे भी इट इज 23 मार्च और बहुत ऑस्पिशियस डे है, तो वैसे तो इंडिया में शहीद दिवस मनाया जा रहा है, बट हम लोग डेडिकेटेड हैं अपनी वुमेन के लिए। हम चाहते हैं कि उनको किसी भी तरीके से उस लिस्ट में न डाला जाए। वी शुड सेव देम।
Yeah, that is true.
Yes, yes. Thank you so much, ma'am. It's nice to see you. अब इतने अच्छे हमारे को भी मेंटर्स हैं भी, और आपको देखकर बहुत अच्छा लग रहा है। नहीं,
हाँ,
मतलब
बहुत
ये
अच्छा। जैसे मैडम हम लोग मैं और तरु और शारदा जन मैडम, मतलब भाई ऑब्वियसली डॉक्टर शारदा जन मैडम, हम लोग ने मिलके अभी मैडम 100 वेबिनार कर लिए हैं तकरीबन, और ओनली वेरी फ्यू हैव पुट एन रियल इम्पैक्ट ऑन आवर माइंड। आज का तो हमें याद रहेगा मैडम।
Thank you. And we are
हाँ,
all
एक
very
मिनट
happy
सहिति
to see
मैडम का
you.
फोटो लो। सहिति, एक मिनट मैडम का फोटो लीजिए। सत्यवती मैम और दूसरी मैम को भी बोलिए कैमरा ऑन
Famida,
कर
why
लें।
don't you come on to she's Dr. Famida Banu. She's my student, proud to say, but we all work together. Famida, are you available?
सहिति, हैव यू
You are
टेकन
in a
फोटो?
silent mode.
सहिति, हैव यू टेकन फोटो?
Yes, ma'am. Yes, ma'am.
ओके,
Have
थैंक
you
यू।
taken?
Thank you, madam.
Sarojini ma'am, we want to see you also.
हाँ, सरोजनी मैम को भी फोटो में लाओ।
How do I
Madam
do? I do
Sarojini
not
madam,
know
मैम खाली फेस
how to
दिखा
show
दीजिए,
my face.
ऐसे करके फेस दिखा दीजिए।
How to show my face, I don't know.
You remove
मैम वो वीडियो पे क्लिक कर दीजिए।
yeah,
video
you
on kar
click
lo,
it on
madam.
your video, madam.
Video on karo.
Acha. Hello.
Yeah,
Thank
Yeah.
you
madam,
very
thank
much.
you so
नमस्कार।
much.
Very
प्रणाम
nice to
मैम,
see you,
प्रणाम।
madam.
Namaste, madam. Even Sarojini madam is
Namaste.
my mentor also. Sarojini
ओ
madam
हाँ,
is
तो
my
बड़ा दिन हो गया
mentor. My
सरोजनी।
She
mentor.
is such
Namaste,
a
madam.
senior person.
Namaste.
One
Very
point I want to
dedicated,
add.
excellent
Yes,
See, I
gynecologist,
have
obstetrician.
please listen. One
yes.
point I want to add. I have seen people getting the baby and then sucking with the mother when the placenta is not separated. So that will increase the pitocin and then it will automatically come out. This I learned from the villages, village women. Thank you.
Recently, we have started this, the golden hour, that we immediately go to the mother and they start keep breastfeeding as early as possible. So this
Yeah.
will also increase pitocin. Correctly
Yeah.
said, ma'am.
Release of
Yes.
oxytocin and then prevents PPH, another thing. So
जो
Thank you.
जो भी
Thank you.
पुराने लोगों का जो भी रूल था, देखा जाए तो धीरे धीरे वही आ रहा, वही एक्सरसाइजेस, वही। न्यू जनरेशन को तो हेल्थ ही नहीं है, जैसे लाइक फ्यू पीपल लाइक मी। और हम जितने सीनियर को देखते हैं हमें लगता है ये भगवान, हमें तो कुछ थोड़ा सा तो सीखना चाहिए कि इतना ज्यादा मतलब काम भी करते थे और सारे कोई डिमांड भी नहीं थी। और यू ऑल बोथ सीनियर टीचर्स, हमारे गुरु मैडम, सब लोग इतने एक्टिव। आई कैन सी सो नाइस मैम, और नजर न लगे। और डॉक्टर अंबुजा, आपको थैंक यू कि आपने इन मैडम लोगों को बुलाया, अभी हमें पता नहीं था, और उनके नंबर भी दीजिएगा हमें।
So nice of you, ma'am. You have come to the webinar to bless your.
आज
Yeah,
रियल
Yes,
ब्लेसिंग्स
madam.
मिली है।
we
आज
are
ऐसा
very
लग रहा
happy
है
to
आज
be
हमें
part
रियल
of it.
ब्लेसिंग्स मिली हैं।
Thank
All
you.
the best.
Thank you.
Thank you.
All the
Make
best
sure
to all
we
of
met
you.
you people and then
May
we are
God bless you.
also happy.